number of hospitals dropped down last year a little bit. There's a wide range of operations performed in the several hospitals, but in the most of hospitals we perform more than 50 operations per year at the moment. First of all, I want to show you some gender-specific data. There's a distribution that we found that more than nearly two-thirds of the patients are female, and only about one-third is male of the patient. If we look further on, there we have the problem in Germany that the patients become bariatric surgery. They are very old. The mean age is 43.5 years, and the mean BMI is quite significantly higher in men than in women, and the mean BMI is 52.1 kilograms per square meter. There's a second very large problem in Germany that the patients have a high prevalence of comorbidities, and there are only about 10% of patients with no comorbidities, and more than 60% of patients suffer from hypertension, insulin and non-insulin dependent diabetes, and a high prevalence of pulmonary comorbidities and sleep apnea as well. And this data will influence our long-term outcome, and we will show this later. If you look to some operation data, so we see that you can see that the operative time is nearly constant during the last few years, and most of the patients were operated by the laparoscopic approach. Conversion rate is only few during the last few years, and you can also see that the bushie size increased during the last few years, but only a slight increase of the bushie size, and the mean resected volume is nearly constant during the last few years as well. Intraoperative complication rate, when we talk about this, is changed during the last years. We had a very high complication rate at the beginning. It's dropped down, but there was a high complication rate in 2005 as well, 2011 as well. But the complications were mostly the liver injury and the spleen injury in our patient. General complication rate in Germany for the sleeve gastrectomy is constant since 2010. It's about 5.5%, and it's not dropped down since 2010 significantly. If we look to the specific complication rate, there we have nearly a constant specific complication rate regarding 2007, when we have dropped the learning curve, and the specific complication rates overall about 5% during the last few years without any large changes. If we look to the Achilles heel of the specific complications, so we find that bleeding is a high complication. The leakage rate dropped down during the last few years, is now less than 2% for all patients, and according to leakage, the sepsis rate is nearly constant during the last few years. So we evaluated for the sleeve gastrectomy the influence of several factors for leakage, and first of all we looked for the BMI of our patients, and we found that the BMI of our patients, or the patients with a BMI between 50 to 60, have the highest leakage rate in our study in Germany, and we were surprised about this effect due to the fact that the patients with a BMI above 60 have a lower leakage rate, and if you look further on, patients with a BMI between 35 to 40 have also very high leakage rate. So we have evaluated further on if there are some different factors for the leakage rate in these patients. Then we looked for the leakage rate in dependence on using different staplers, and if you see that if we use the stapler alone, we have a leakage rate of about 2.3%. If we use stapler with oversewing, the leakage rate dropped down, as well as you use a stapler with staple line blood process, and you see that's no difference, no significant difference if you oversew or if you use staple line blood process, but you have a very worse scenario if a very, very high leakage rate in these patients. Then we look further on the influence of sex, and you see that the male gender has a quite significant influence on the leakage rate, and male people have a higher incidence for leakage in the German bariatric surgery registry. First on we looked for the comorbidities, and we found there's not a really strong significance for some comorbidities. There's no influence of the diabetes on leakage. There seems to be an influence on hypertension, and we found the influence of sleep apnea and nicotine use for the leakage after sleeve gastrectomy, especially in the leakage on the angle of his. Mortality rate in Germany is low, but not so low than in the data published from the US studies and from the World Register. That's a problem, and we have also further influence and evaluate if there are some other reasons for the high leakage rate and the higher mortality in Germany as well. If we look to the follow-up data, so we have now follow-up data of about 4,000 patients after sleeve gastrectomy, and if you see all the patients had a BMI, from patients we have follow-up data had at the beginning a BMI of 52 kilograms per square meter, and the BMI dropped down to 37 kilograms per square meter, and you see further on that the patients in the mean have a loss of BMI of about 14 kilograms per square meter, but you can also see there's an increase of the BMI after the second post-operative year, and so we have to see if there's a further influences. There's only a few number of patients at the moment in this state of investigation, and you know that the follow-up data are not on the follow-up examination is not covered by the health insurance system in Germany, and so we have a big problem to perform exactly follow-up and reach follow-up data. If we look to the amelioration of comorbidities, you see that after sleeve gastrectomy there's a high number of reduction of comorbidities and a high number of remission, and we are now in the state that we want to perform further statistic analysis and intention to treat analysis and propensity to score analysis if found that we can evaluate our patients better for comorbidities and for the outcome of our patients as well. So finally, we can conclude that specific complication rate dropped down for sleeve gastrectomy and is now less than 2%. Female patients show a lower significant complication rate than male patients. Leakage rate is higher in patients with a BMI above 50, with a BMI between 50 and 60 kilograms per square meter, and it's similar and without no significant difference in comparison of overskewing or stabilizing mattresses. The overall BMI reduction for the German patients with a high age, a high incidence of comorbidities, about 14 kilograms per square meter, with a good amelioration of comorbidities, but we need more data and better data for reoperation and long-term outcome in our patients. Thank you for your attention.
Time for one question. So now we have a change of direction. We want Dr. Casey to talk about constructing feasible training of surgeons starting in bariatric metabolic surgery. Dr. Casey.
Mr. Chairman, thank you very much. We talk about the training for bariatric surgeons, and I have to do at the beginning that in 1990, when I decided to begin this activity, I met this man, and Nicola said to me, "Are you sure of this? Remember that it's a very difficult field. It's not only a surgical problem, but a cultural problem. You need to study obesity, you need to know the complication." to study complications of obesity, you have to know the comorbidity of obesity. And so, because if you speak about the technical problem, we have to remember that bariatric surgery is not, I don't know why, is not different from surgical field, from general surgery, except for gastric band. Other procedures are common to general surgery. So, in this article published in the American Journal of Surgery, they say that most of general surgery residency doesn't include bariatric surgery, and it's difficult to develop a specific program in a general surgery residency. And we need a learning curve, and several publications suggested that the learning curve, for example, for Roux-en-Y gastric bypass is at least 7,500 cases as a primary surgeon. In this article, very interesting article from a Spanish group of Professor Torres, they analyzed the data about 18 different surgeons with 1,800 patients. Surgeons were divided into two groups, without a formal laparoscopic bariatric training and with a formal bariatric, a specific program. As you can see, in the group 1, they didn't have a specific training in bariatric surgery. In the group 2, all the surgeons had this. Just a few of these surgeons had a previous experience in open bariatric surgery, but they had experience in laparoscopic surgery, and only group 2 had a specific training. As you can see, in the second group, we have a very different data. No mortality in the group 2, and mortality in the group 1. But if you look at complications and morbidity of these groups, we have a low rate in the second group and probably high rate in the group 1. So this explains why we need a specific training. The postoperative complications, we say it was 18% versus 7% in the group 1, and 0.5% different in mortality rate on the different group. We have a higher incidence of leaks or stenosis and occlusion in the group 1. So, American Society in the 2007 underlined these training guidelines in under weight loss operation, primary surgery, as a primary surgeon in at least 51% of cases. And there should be a minimum of 50 stapling operation, at least 10 restrictive operation, and 5 open procedures. The surgeon must participate in 50 patient preparation evaluation, 100 postoperative management encounters, and 1,000 postoperative outpatients evaluation. The Ifso, in this article by Professor Marissas, the guidelines, they distinguished the center, different centers on basic, on bariatric institutions, and they recommended not to accept it in this at the beginning of the experience, not to accept the supervised patients for the best period, and then in the second bariatric institution, surgeons with at least 50 bariatric cases per year, able to perform revisional surgery by open and or laparoscopic approach, and a lifetime follow-up. For center excellence, as I speak about before, at least 50 bariatric cases with revisional surgery, involving in the training for less experienced bariatric surgeons, and most important, a follow-up for at least 75% of patients for 5 or more years. Our experience, I'm Italian. In Italy we have a school, a new school, and this is our admission notice, and we accept Italian and foreign citizens graduate in medicine, specialized in general surgery, and this is a course, a 2 years course, and very close is the course, and we expect a frequency of 1 week per month, 5 working days for 9 months per year, and we guarantee in the 2 years 30 operations as first operator and other 30 as second operator. We have 6 centers with among our center of excellence. So we need a multidisciplinary team with these specialists, and why we need a multidisciplinary team? Because of complexity of this disease, the difficult of patient management, the chronic disease course, the protocols, ABM, and first step I think for a surgeon is the analysis of literature, a qualified school, experience in center of excellence. The second, set up a multidisciplinary team with a specialist this is very important, who really trust on bariatric surgery as the only valid long-term therapy. Third step, set up an outpatient office and will be able to select each patient for each surgical procedure with a post-operative lifetime follow-up. This surgeon need constant effort in order to increase the public awareness on the concept of the obesity as disease. Professor Goldberg will speak about this. Last step of performing the first operation tutored by an expert surgeon in that specific procedure, perform the first re-operation, the surgery, in collaboration with a bariatric surgeon of great experience. So, our proposal for a tracking point model is experience in open and advanced laparoscopic surgery, cultural background, attend a qualified school or a bariatric center of excellence, start personal experience with a skilled tutor, and then organize a multidisciplinary center, follow literary and congress stably, and participate to national and international registers. Okay, this is our resident performing the gastric bypass. It's easy to reach this probably in the USA or in UK, but not yet so easy in Italy. Thank you very much.
And for respecting the time, and I would like to call our current Ifso European Chapter President of the Xvii. It's going to be a slight change in the time of the talk. He's going to speak about data from Russian bariatric registry.
First of all, I have to apologize to President of the Congress, Mustafa Tashkin, and to the audience for change of the topic. When we were discussing about organization of special symposium devoted to national registers here in this Congress, he asked me to search situation around East Europe region and Balkan region, but lately it has been clear that this is not very easy task, and this work needs additional time, additional efforts to realize what is the real situation there. So I will be speaking about development of registry in my country, and probably have to think about how to improve statistics in Europe, how to improve statistical reports in Europe, and how to develop international registry to which you work all around Europe and around the world. This is a small piece of outstanding job of Professor Bakov, who in 2004 began sending surveys to national societies to explore what is worldwide situation with the bariatric operation. And now we have results of 3 such worldwide surveys, and as a result we can follow the tendency of bariatric surgery worldwide, and we see how changed the situation with gastric bending, with gastric sleeve, and with other operation, and how it looks among countries. So we may see difference between the United States and Brazil and other countries in development of obesity surgery. I see Russia is takes not prominent place in this list, but this work inspired us to develop a national registry, because this statistic, of course, as Professor Bakov told, that is one of the weaknesses of this study. It is very approximate, so not many countries have now their own registers, like developed like in Germany, as we see now, and in Italy, in the United States, in the United Kingdom. So this inspired us to develop a registry in our country, in order to have more prestigious statistics and more prestigious to see the tendencies of development of bariatric surgery. And the survey, this very simple survey, was further developed by Luigi Grisani, who ascended in the beginning of this year a very simple survey to all national bariatric society. And unfortunately, I have information that not so many presidents replied to this survey, and we have no exact statistic update. But the advantages of this survey is very easy to complete. Every researcher may simply, during some minutes, answer for these questions, and possibility to use different databases from different surgeons and opportunity to involve maximal statistics internationally. And as for when we developed this registry, so in 2011, there were 83 surgeons recognized in our country, and 83 of them responded to this to our survey. And surprisingly, in last year, there were less surgeons, less respondents. But the total number of operations were almost the same, with a slight tendency to increase between 2 years. And geography, Moscow, almost 2/3 of operations, St. Petersburg, and the rest of Russia, only about 20% of operations. So, kinds of operation in our statistics is gastric bending. Gastric bending is tended to decrease, gastric sleeve to improve, and similar situation with gastric bypass and BBD and BDDS twofold decrease, and some other operations. Laparatomy versus laparoscopy, the relation changes in favor to laparoscopic surgery. Mortality is low, and since July of this year we started a new model of registry. So this is an example. It's very simple to complete it. More than 300 operations we have gathered during these 2 months. So one of the advantages is that at the same time we can see diagram, we can see tendency, and So in this new Russian register, you can see the percentage of new registered operation done during this year. So, but of course, not many surgeons are involved in this process. So we can, of course, this does not reflect the general tendency of surgery and general distribution and distribution by age, by BMI of patients, and prevalence of type 2 diabetes, ASA grade, and the geography of the patients who operated this year and who were included into the new statistic. So this new system, new registry has of course some advantages. It is a powerful tool for collecting and sharing national data on bariatric procedures and real-time graphs and charts reflecting the most current data, easily adjustable fields for conducting multi-center surveys and trials, and flexibility to manage with data. But of course, limitations are that it's now available for not so many surgeons, so we cannot still have real statistics. Why it is necessary? So this is a basic audit of the results of surgery, analysis of tendencies of every center, every country, nationally, opportunity to compare data with others, and results of different operations. To provide scientific work for, first of all, multidisciplinary studies, and of course, popularization of bariatric surgery. What is necessary now? So, my opinion is that we, as society, have applied to all surgeons to present their statistical report in a very simple survey, at least. And national societies, national presidents, we need to apply to present their data. But at the same time, we should develop. So we should involve more surgeons, countries, and societies to the worldwide new developed service and new developed registers. So thank you for your attention.
Thank you for keeping us to time. We now present our last speaker, Dr. Boria from the United States, who's going to talk to us on long-term follow-up and evaluation of outcomes in bariatric surgery. Dr. Boria, we're looking forward to hearing what you have to say.
I want to thank Professor Taskin and the organizing committee for this invitation. I was born and became a surgeon in Argentina, moved to Houston, Texas in 1980, and soon after I became involved in the surgery for obesity. I was there when the society was founded and everything, and I was very active for a long time in the society. So I'm kind of an old-timer, and I'm happy to see new surgeons now taking over. This is the outline of what we are going to talk. I see a constant problem. We have improved tremendously in the techniques and the reduction of complications in morbid obesity, but we don't sell the product well. That's one of our problems. We have to find outcomes, and we do have good outcomes, but we need to present that in the proper way. There are many difficulties, and the most common one is that we don't have long-term follow-up. It's mostly 1-2 years, and that is totally insufficient. We have to do a complete assessment of outcomes. But the main problem is that we don't have standards for comparison of results. We don't present the statistics well, and we don't have a definition of success failure. After 50 years, we do not know how to define success. And that's what I'm going to try to talk about. Length of the follow-up. Like I said, we talked about preliminary results. Please don't use that. Obesity is a chronic disease. Presenting results at 1 year is absolutely not valid. It's worthless. We have to try at least between 5 or 10 years. And of course, the ideal would be more than 10, but that is very, very difficult. The intensity is different according to the technique that is done. Maybe gastric banding doesn't need a lot of laboratory studies. But it's actually important to present in the follow-up the number of surgeries done and the number of patients follow-up. We need to present also how many patients we lost completely to follow-up, the median time of follow-up, and the reoperation rate per year. It's not very used right now. Dr. Mason talked about this long time ago. Can you imagine if we had used this when gastric banding was going crazy all over the world? If we have analyzed how many numbers of operations we were doing, increasing, and we could have prevented what is happening now with the banding. This is a simple graphic. It was used by the National and International Bariatric Registry that was created by Dr. Mason way back in the 1980s. And you see in the 5 years the number of patients that have been done and the actual number of patients that were followed. So this makes sense. And we realize, even in this graphic, how poor was the follow-up, and we haven't improved much, unfortunately. All right. The other problem, look at these definitions. I'm not going to read them for them. Completely different. They use weight loss as a main parameter, but the definition of Dr. Boris is much stricter than Freeman's. Mason is only half what Halverson decided, which is what a lot of surgeons use. And then there are brain, whole and leg, there are so many other classifications. However, let's be very clear, weight loss is an insufficient parameter. That's why we need to analyze the comorbidities. This concept was introduced by Rowling and his colleagues in the 80s, but it was not adopted because they failed to list the medical conditions to be analyzed and to define the diagnostic criteria, the degrees of severity, and also they talked about resolution and improvement of comorbidities, but they did not define that. So the organization Shape Up America in the mid-90s decided to work in this and created two types of major and minor comorbidities, as you can see in the slide. However, it's not always that clear. For example, I will submit to you that a female patient with very serious urinary stress incontinence has a quality of life much poorer than somebody that has a mild diabetes and takes just some pills to control it. So the definition of major and minor, it has to be also related to the analysis of quality of life. There are genetic instruments, and the most typical is the short form 36, others are more complicated, and they are disease-specific quality of life indexes. They have to be reliable, they have to be valid, responsive, and sensitive. But they also have to be short and have to be simple, so every cultural level can respond to the questionnaires. In 1991, there was an NIH conference on surgery for obesity that was pretty much